Hi, I'm Mintrone Francesco, and I would like to introduce you a new lecture on the optimal treatment planning or optimal prosthetic treatment planning. And it's not easy. I think that's the first step of our therapy, and several times we miss just to focus what we want to do in the mouth. And so for this reason I decided to create this lecture. And I think the first point when we start to treat the patient, we have to understand that for us really important is the external evidence. When we treat the patient, we must find what is our technique in the literature and evaluate our technique. And then the internal evidence is something different. We have a different technique that we can find in the literature, and internal evidence is what is working in our hand. With two techniques, probably we are much more prone to use one, and this is what is the internal evidence. And then for sure, what is really important is the wishes of the patient, that for us are really important. We can understand what the patient wants, and with this approach, we can really create an evidence-based health care, of the patient. And so after that, we can start to evaluate a circle that starts from what the patient wants to the data collection. And we will see in the data collection, we will have the model, the face bow, or we can evaluate the muscles, the TMJ, and the aesthetic rules as well. And our hypothesis of treatment is something different. It's the idea of aesthetic that we want to give to this patient. And then the previsualization is the phase in difference where we are going to print in the mouth or evaluate in the mouth this aesthetic, and we can discuss with the patient if this aesthetic, this rehabilitation is something that covers the wishes he has. And with this in mind, we can create an optimal treatment planning, and then we can start a really active part of the therapy that passes through a provisionalization, and then all the surgery, and then to get the target, so the final rehabilitation. In the red circle, so the provisionalization and the target are the irreversible phases. So it means that until we don't touch anything in the mouth, so until we didn't use our scalpel or our bars to prepare something, we can get back. And if the patient is not happy about what we give as idea of the final result, we can work on that. So consider our treatment plan. I think that the vaginal generated treatment plan is the idea. So we have to start from looking the face of the patient. We cannot start a case looking with the loops inside the mouth. So if we have to consider the face, I consider also that the aesthetic is the first step, and so we have to start to evaluate the case from the aesthetic point of view. And then function, structure, and biology. It's in this sequence are how normally I evaluate my patient and my cases. And then, first of all, we have to understand what the patient wants. What the patient wants, it means that sometimes some patients come only for the pain, and then we have to fix the pain. Some other for localized problems, so a dark tooth, for example, and we have to try to solve the problem. But really important for us is to evaluate sometime if the patient is interested in aesthetic and functional rehabilitation. It means that not all the time we have to prepare all the teeth, but if we have 3-4 problems in the mouth, we are going to fix all of them in the way to restore completely the aesthetic and the function of the mouth. So if we consider this kind of approach, immediately we have to understand that in the United States, 3.6 billion US dollars are spent every single year for the malpractice. And inside the category of doctor that can commit malpractice, there are also the dentists. And for me, it's really important the article that we have beside that I found on the JOMI, and where we have patients that normally complain about the implant, and it's are more or less 82% that sue the dentist for this reason. And most of them are female, so we have to take care about this as well. And it's important to understand that most of the time the clinician don't have any kind of proof of the idea he had of the treatment plan. So he have no cast, no X-ray, and for this reason a lot of time we have trouble for this reason. So every single time we start with a treatment plan, take picture, take your study model and keep all of them, just in the way to document all the phases of your treatment. And then what I want to see, what I do normally, I try to use the visual communication with my patients. So I try to use my presentation. I start to create presentation for my patient, not to speak in a congress or in a lecture. And then show, for example, magazine and explain why we want to have in rest position teeth that are visible between 1 and 5 millimeters. And then if we try to explain all these different phases and the idea of aesthetic that we want to get, probably we will have less trouble and less problem. And it's interesting to see that if our information is not focusing on the marketing, but in the proper information to the patient in the way to get a more high acceptance of the treatment, probably we are in the right direction. So use old presentation, similar cases, and use a visual communication. It's our idea to communicate with the patient, much better than use 1,000 words. And for this reason, we want to keep all this information with us. So photography, X-ray, static cast, and so on. So starting later with the point 2, so the data collection to hit the target, I think that we have to start evaluating cast, bite, bite registration, face bow, aesthetic evaluation, occlusal evaluation is really important, periodontal evaluation, and all the other evaluation that we will see in a step-by-step of this collecting data together. And then, first of all, when we need a study model, and so when we have to start a new case, I would like to suggest you to start with a polyether and an individual trade, just in the way to get a really precise impression. And then the casts that we will obtain are to keep in our office, just to prove as the start of our therapy, just to have an idea, so we don't have to use this. We can make a copy of this cast, and then if we have to do a provisional restoration, we can use this in this copy, not the original one. And when we take an alginate, and sometime we ask also to the assistant, just because we are in rush, please, or the hygienist to take an impression. But look, if we go in a simple way like this, what we want to have is two beautiful casts. And if we look the details of the cast that we can obtain with one material or the other, you can immediately understand that in the cast that we obtain from an alginate impression, not a really precise one, there are a lot of bubbles, and so the detail are much less. And this can create a problem in evaluating the stability of the occlusion, for example, or evaluating in general the situation that we have in the mouth. And just, I don't know if you saw, but in my presentation in the beginning, in the circle, I put an asterisk, a red asterisk, because we have to collect the data, also the digital path. And so when we consider the digital path, right now we can start with an intraoral scanner in the way to take impression. For us, it's a technology that is start to become common. And we can take a nice impression right now with the last device that we can find on the market. It's quite easy, they are quite small, and we can get also the back part of our teeth, so the distal part of also of the molar, and then it's quite easy. In 2.5 minutes we can take an impression. And when we see, this is not only the impression, for us it's also the digital cast, as you can see here in detail. And right now also the accuracy of this technology start to become really important. And then when we start to speak about bite registration, here it's everyone has an idea in how to create a perfect bite registration. First of all, we have to understand that if we have to do a single molar in the lower jaw, for example, and that the occlusion is stable, the technician doesn't need any kind of bite registration. It's much better to have a clean and precise cast, and then it will be used to find the occlusion through the evaluation of the facet. And but if we, for example, we are going to make a full arch, or in a case like this, a full mouth rehabilitation, and we need to increase the vertical dimension, for example, just to have a minimal invasive approach to the prosthetic rehabilitation, it's important for us to have a precise evaluation of the CR position. So a position that is not related to the position of the teeth, but it's related to the position of the condyle inside the fossa. And for this reason, we can use different material, and, but what I prefer is to use an anterior deprogrammer. That can be a Lucia jig, can be a lift gauge, or a customized anterior deprogrammer. And much more, the technique that I prefer is to use a really thin plastic foil created on the master cast in the way to have really precise seating of the bite registration inside the material. Why? Because if we use, for example, hard material to take the bite registration, that for us are really important, because if we take something soft, we have no precise position. As you can see here, the difficulty come at the time that the technician have to put the cast together, because this detail that a hard material can take inside, for example, the little grooves of the teeth, after it becomes really difficult to put the cast together. For this reason, if we start with the plastic foil, as we have in the left part of our screen, for the technician will be much easier to find the occlusion and the precise position of the arches. As you can see here, this is the case, and I want to show you how normally I do in these cases. So in this patient, for example, we decided for a full mouth rehabilitation, and right now we want to increase the vertical dimension because the patient lost the vertical dimension, and also to improve the aesthetic of the face. And so we are fitting right now this two plastic foil, really thin plastic foil, with and then we are going to use an anterior deprogrammer, as you can see here, that was adjusted to the right vertical dimension. And then we are going to ask the patient to move forward and backward in the way to evaluate the path. And as you can see here, we can check this path inside the anterior deprogrammer, as is here. And then what we can do also is to check this position through the use of the bimanual maneuver of Dawson in the way to check if we are exactly in the same position. And as you can see here, for example, the blue and the red mark was exactly in the same position. Then we ask the patient to move forward and backward, and then we can, without squeeze, we can ask the patient to stay where it is, and then we are going to put this hard material to fix the bite together. And then we remove everything, and then for the technician it's really easy to put the two casts together and have the opportunity to check the proper CR position. So the starting point of our WhatsApp or our occlusal evaluation. And if we consider the digital path, can we do the same? Exactly, we can do exactly the same. We are not using the plastic foil, but as you can see here, we are going to use the anterior deprogrammer at the right vertical dimension in CR position, so exactly in the way that we checked before the CR position. And then what we are going to do, we are going to scan the two arches together, going first from the lower one to the upper one, or in the opposite way, it doesn't matter. And this will give us the opportunity to match this position and with the impression of the two arches. And as you can see here, right now we have our bite registration in CR position. And with the new technology, for us it's easy right now to check the space, to check and evaluate the position, evaluate every single detail before to start with any kind of workshop, digital workshop or other kind of therapy, and we can explain much better what kind of problem we have to the patient. And then what we can do, for example, is to evaluate also another stuff. For example, look at this other mouth, where we have an important abrasion and erosion of the mouth, and so we want to check the occlusion. So we ask the patient to close, and as you can see here, we have contact point in the posterior area, but there is no contact point in the anterior zone. And so for us, we can already understand that we have some trouble. Probably the patient have like bruxism habits, and then as you can see here, we have a mix between erosion and abrasion. Another step is the face bow. Remember that if you give the face bow to the technician, it will be much easier for him to evaluate the position of the upper arch or the horizontal reference, and then start, if you say, for example, that you want to organize the occlusal plane parallel to the horizon of the patient. That can be the bipupillar line, for example, or another horizontal reference. But in any case, if you give the face bow for him, it's really easy because he can assess the inclination that the patient has already on the articulator. And then if you ask to move something, he can understand precisely what is the situation. And it took normally 1 minute, something less sometime. And as you can see here, after we fix everything, we check with our horizontal reference, in this case was the bipupillar line, and then we take it out and everything is done. Always speaking about the face bow, we can go also in another way. We can go also digital. And interesting is to evaluate a natural head position, that it can be great. It's a new way to go. It's a new reference. We have no, in this case, reference of the Frankfurt plane or the Camper plane, but it's the patient that normally, when stay in front of you, keep the head in a natural position, and this is what we want to record. And to speak about that, I would like to propose you something that is different. So it's the digitalization of the patient, and through the use of this device, that is the face hunter, we can check the position of the upper arch inside the face of the patient. And as you can see here, we are going to take a picture, three-dimensional picture of the face, to create a three-dimensional patient inside our computer. And as you can see here, I'm taking picture, and then combine it together, we have a three-dimensional evaluation of the patient. This is the scan fork, so it's something that will help us in the way to fix inside our digital patient, inside the computer, the position of the upper arch. As you can see here, after I take this kind of photo, I can match together, finding the precise position of some point and overimposing one picture to the other. And then after what I have, it's a patient that can be in rest position, in smiling position, and this is what we can have, a three-dimensional patient inside our computer. And then we have not only the face, but we have also the teeth exactly in the position that are in the reality. And plus, we can also align the DICOM file, so we can have also the bone of the patient exactly in the right position. So you can imagine that right now we can make any kind of diagnosis inside the patient. So we have a digital patient, and we can share information, and we can also evaluate much better the situation. Going in the normal way, getting back to the normal way to go, but it's really important for us, it's to evaluate photography and videos. Because if we consider the photography, the photo is a static moment of a dynamic phase. So for us, the videos are really important to assess how it's moving the patient and the natural expression of the patient during this phase. When we have all this data, we can start to evaluate the aesthetic and collect the aesthetic data. And so, for example, the rest position is really important for us. We know, for example, that the rest position is really important for us to detect if the teeth are visible or not. For this reason, right now, with the group in which I am, we are going to create an app, Get App. And it's an app that will give you the opportunity to evaluate the patient and then create an aesthetic analysis that can be shared with the technician in the way to create the proper treatment plan. And always looking at this aspect, what is important for us is to evaluate the incisal trend, so if it's convex, flat or concave, and if there is any kind of inclination, because these are all the stuff that we want to correct if there is any kind of problem. And always with this application, with the Get Up, we are able to create something that it will be really useful for the technician, but you will see soon this kind of app. Moreover, when we start to make our occlusal evaluation, what we want to start to evaluate is the mouth opening. So we know that it's normally between 40 to 60 millimeter. And for us, it's really important, for example, to detect if there is any kind of problem in the TMJ, but much more, because if we have to do, for example, a guided surgery with tilted implant in the back, if we don't have a proper mouth opening, we cannot provide this kind of surgery. And moreover, we have to understand if there are any kind of noise or inside, like click, pop, or with the palpation of the muscles, and to evaluate if we have some problem related to the TMJ and the muscles of the mouth. And really useful for us, it's the load test. What is the load test? The load test is, we can use, for example, the anterior deprogrammers that we saw before. We ask the patient to move forward and backward, and when it's in the backward position, we ask the patient to squeeze. If the patient starts to feel pain, probably it's a case that we cannot solve with the use of the CR position. We have to evaluate another position. So in difference, if the patient doesn't have any pain, probably for a full mouth rehabilitation, I will point to the CR position. Much more, if we have to analyze if the patient has some trouble, some pain, and we want to evaluate if it's a pain related to the muscle or to the TMJ, what we can use is the stabilization test. And this is something different. It's, we have to keep the mandible of the patient fixed, and then we ask the patient to move in one side, for example. If the patient doesn't have any pain, it means that it's a problem related to the joint. If the patient keeping the mandible fixed have pain or increase the pain, it means that it's a muscle problem. So related to the muscle, then during this contraction to move and with your hand that fix the mandible, it can increase, okay, this pain. And so for us it's really important as the starting point, because in a case like this, where for example we have to evaluate a full mouth rehabilitation with the use of implant, and then we want to create a new provisional restoration for the time in which we are going to place the implant, and look which huge difference there is between the maximum intercuspidation and the CR position. If we are going to use the maximum intercuspidation, for sure it will be a problem to fix later the provisional restoration in the right position. If we go and we prepare the new provisional restoration in the CR, for us will be really easy to find back this position at the time of the surgery. So for us become really important. Collecting data, I think really important to make an endodontic evaluation. And so what we want to do is to have a predictable result and long-running result. And so every single time we have to treat teeth that are already endodontically treated, and there are no periapical reaction, and we don't violate the endodontic environment, probably we can keep, if there is no problem on the periapical region, we can keep this endodontic treatment. But every single time we are going to get back in the endodontic space to create a post or something like this, as advice, I will say that it's better to go for a retreatment of the tooth, that to be sure that we eliminate all the bacteria that can create some trouble. And if we don't, what we can have is our trouble like this, where a periapical reaction is contaminating in some way the surface of our implant after a while. And so this is a problem that we can have. Speaking about the periodontal aspect, what I want to only suggest, every single time you start with any kind of therapy, I would like to take care about this aspect. And for sure, evaluating the review of the randomized clinical trials, this article of Science that you can see, we know that the scaling and root planning can give us a really good approach in the way to eliminate all this biofilm and in the way to create a really healthy situation in the mouth before to start with any kind of therapy, any kind of evaluation if some teeth are to keep or to remove. And then moreover, what we want to do and what we want to evaluate, it's if we are in a situation like this, where we have a tooth that's a lateral incisor, and we don't know if to keep or to extract. And we know, for example, that we need the ferrule effect to have a really predictable result long running. And in a situation like this, even if we go for an orthodontic extrusion of a tooth like this, probably the structure of the tooth, it's not really strong. And in this case, even if we have 2 millimeters of ferrule effect just for the dimension of the part that there was inside, it's not predictable. And much more when we look always in the aesthetic zone situation like this, if we decide to go for a crown lengthening, for example, remember that we have to evaluate aesthetic. If we are in the posterior area, probably we can use this kind of approach without really important evaluation on the aesthetic. But if we are in the aesthetic area, so in the visible area, we have to consider also this aspect. So we cannot perform a crown lengthening if all the teeth are at the right level and the right soft tissue level. So this will create a problem. So in these cases, for example, in a tooth like this, what we want to do is to evaluate the case, but if it's not in some way a tooth that can be predictable for a long-running restoration, we have to go for the extraction and the implant placement, as you can see in this case. And for sure, we have to evaluate also function, because if we have a canine, for example, and we want to have a canine guidance, and we are so-so, the structure is not so strong, and we cannot do anything else, also in this case, we can point to an extraction. And if in some cases there is nothing to do, even if it's not strong, and we can solve with the filling or something like this, probably we can accept the risk. But every single time we go with the crown or with the rehabilitation, especially if we pretend to do a full mouth rehabilitation, aesthetic and functional rehabilitation, we have to take care about this detail. When we come to the chapter of the aesthetic rules, what we want to have is an aesthetic analysis and understand how we have to solve some problem to improve the aesthetic of the patient. Aesthetic method right now, nowadays it's really important. We need to make a dental labial analysis, a dental analysis, and a gingival analysis. And so, speaking about the facial analysis, what we want to have is to restore a proper parallelism between the occlusal plane and the horizontal of the horizon of the patient. And in this case can be the bipupillar line, but it's not always the bipupillar line. It can be also something different. And so in this case we have to know we have to detect that if there is a parallelism between the bipupillar line and the commissural line, and then we have to judge if in this case our parallel, we are going to keep the bipupillar line. If there is a discrepancy between these two lines, so commissural and the bipupillar line, we have to find sometime an average line or the horizontal line, or sometimes we prefer to stay close to the inclination of the commissural line. And for sure, in the facial analysis, we have to evaluate the dimension of the lower third of the face. So recreate the vertical dimension of the face, and the lower third of the face for us, it's a really important matter when we speak about aesthetic. When we go to the dentolabial analysis, for us it's really important, as I told you, in the rest position to evaluate how much the patient is displaying the central incisor. We know that normally it's between 1 to 5 in relation to the age and to the gender of the patient. But in any case, in this evaluation, we have to create a proper position of the incisal edge. That for us is the first important step of our therapy. Once we have found this position of the incisal edge of the central incisor with the proportion, we can detect where we would like to have the free gingival margin. And then also the position of our implant, because we know that we want to have the implant more or less 3 millimeters away from this line, so from this free gingival margin. And right now, stepping in the dental analysis, what I can give you as advice, if you want to really obtain an aesthetic rehabilitation, you have to choose a really good technician. Even if you are really great with the surgery and you don't have a really good lab beside you, the rehabilitation never will be really nice as it can be. So with the help of a great technician, so for us it's really important to evaluate the technician. Remember that with DHL you can cross the world in a couple of days, so it's not a big matter, the distance, okay, for our technician. So what we want to have, it's not crown, but we want to have teeth. For us, it's really important. And then for the gingival analysis, in the same way, what we want to have is a parallelism between this line of the gingiva and the horizon. And so for us, it's really important in the way to have really a comprehensive aesthetic of the mouth. And then after all this evaluation, we can jump in the fourth step, in the fourth chapter. And for us, hypothesis is the idea of aesthetic that we want to have for our patient. And then how we can give this hypothesis to our technician in the way to make a works-up. First of all, we have to give an idea. And right now, really, we are familiar with the digital smile design because for us in the last period, it became really famous. And I think it's really important tools for some reason in the way to communicate with the patient and communicate with the lab. But remember, the digital smile design, it's a tool, has its this beautiful motorbike. But if we don't know how to use, is this guy, Valentino Rossi, in our right, probably the motorbike doesn't go as it can go. I mean, you cannot win. So it's important for us to understand how to be the pilot of your therapy. And so for this reason, for example, we can choose the option number 1, 2, 3, and 4. And the digital smile design gives us the opportunity to design this teeth, but we have to learn where to place this teeth. Okay, and then according to this aesthetic analysis that we saw before, we can start to create this hypothesis. And remember that for example, between the solution 1 and solution 3, there is a huge difference, because in the solution 1 we can go almost without preparation with no prep veneers, for example. In the solution number 3 we have to go with an aggressive crown lengthening, and then we have to go for waiting for the maturation of the tissue, at least 6 months probably, and then go for crown or veneers or better, whatever we want. But so for us it's really important to understand that the digital smile design is a tool, but we have to know how to use it. And then when we speak about implant, for us our hypothesis is only the provisional denture, for example, and or the mock-up that it's like a denture, because in this case, for example, case number 1, we will place an implant in a way. Case number 3, we are going to place the implant completely in a different way. So we have to know our target before to place implant. And look what can happen. I found on internet this picture, and it's clear that the guy have a precise idea of the future restoration, because right now for the technician it become a nightmare to restore a mouth like this or to restore implant like this. And so every single time we are in the natural dentition, we can create like a digital smile design. So just in the way to inform the technician what he have to do, how he have to create the workshop. Every single time we go for a dentist patient, for example, our hypothesis is the new denture. And then we can help the technician to mount the teeth on this denture to use a really precise setting of the bite registration. Normally I use also to put some central incisor in my bite registration in the way that I can fix inside the mouth and then adjust, for example, the exposition at rest of this central incisor, and for the technician become really easy to go forward. And then can we do the same through the use of the digital path? Yeah, for sure. For example, look at here, this is our patient that we saw before, and then we can start to make a workshop, a digital workshop, and with beautiful shape, and then we can adjust the length, the position, and the dimension of this workshop, and then we can find the aesthetic. And right now for us it's really easy to see, for example, with plan. Look at here, right now I'm planning to position my central incisor, the canine, and the lateral accordingly to my horizon. For us it's really important to evaluate a situation like this. And then we can share with the patient this idea of aesthetic, and then we will analyze much better in the mouth of the patient when we will have the pre-visualization, so the next step. But look at here, for example, I can detect the bone, where is the bone, in relation to my future restoration, and so I can understand if I can place the implant in that way or in the other way. And if I have, for example, some kind of defect, diascence or fenestration, and then if I can go with the technique or the other, before to start. And this is for us, it's really important. So can have the opportunity to find all the information before will give you the opportunity to go straight to the target. And so as you can see here, I'm right now putting all this workshop, digital workshop in the mouth, and then checking the aesthetic with the plan and nothing else. So right now the future is to evaluate in the mouth of the patient, so we can have the pre-visualization. The pre-visualization for us is really important. We can evaluate function, we can evaluate aesthetic, we can evaluate a lot of stuff before to start with the active therapy. So for us, for example, if we, with the pre-visualization, we can check with the patient if he agrees with this kind of aesthetic. If the patient doesn't agree with the length of our central incisor, we have to understand what to do. And then when we have clear idea of what we want to do, we can go forward. And so what kind of pre-visualization we have? We have different on the natural teeth. We can go indirect, so it means that technician is creating for you like acrylic veneers to put over. You can go with the semi-direct technique that it starts from the workshop and then you print them out, or you can go freehand if you want, in the way to understand the shape, the length, and then you can start to share with the patient your idea of aesthetic, your target, and the patient will understand really well what you want to do. Look at them, for example, this video. This is a patient 1 hour later, so before and after this pre-visualization, this mock-up, and you can see immediately that how much the patient changed. And do you think that if you are going to show a video like this to the patient, it's not going to accept your treatment? You cannot understand the value of your treatment? I think it's really important for us in the way to go in the right direction from the beginning. So pre-visualization can be really, really good. And what about implant? If we are moving, for example, in an edentulous patient or partial edentulous patient, what we can do? We can do a new denture, where for us it's really important to have a sharp angle between the white and the pink, and we will see later why. And we have to test also if the patient can support a rehabilitation without the anterior flange, because we know that with the anterior flange, the lip support is much more important comparing what we can do without. So if we see that the patient cannot, the lip support is not enough, if you go for a fixed restoration, probably we have to do something different. And also we can do partial evaluation. This pre-visualization for us, it's really important. We will see later why. And the surgical implication of the previsualization are several. For example, in a case like this, we can understand, for example, if our approach will be an approach without any kind of surgery, or if our previsualization, our mock-up, is going over, it's overlapping the tissue, we have to evaluate, also considering the biological width, the distance between the free gingival margin and the bone that we have. And then we can go, in some cases, with an internal bevel, that it's the easy ways to go, and we can wait 6 weeks to have the healing and the stabilization of the tissue, or in some cases we can go for a buccal resective therapy or for a buccal and palatal resective therapy. And this makes a big difference in the healing time, for example. And what about when we go for an implant, and so we make like a prosthesis? If we have a sharp angle between the white and the pink aesthetic, through the use of this kind of software, we can design this yellow line, and looking inside the section, we can place the implant 3 millimeters away from the future free gingival margin, and then we can understand if it's a case where we need a GBR or it's a straight case. And then we can explain to the patient, we can understand better the situation, and probably we will have more high acceptance of our treatment, and he will understand why the therapy it takes so long, for example. And through the use of this digital approach and planification of our treatment plan, starting from the previsualization, what we have to do is we can start right now to plan, because we have the target inside the software, and we can, on implant, we can start to plan the position of our implant. And then we can go also for the guided surgery. So right now we would like to speak about accuracy of this kind of technology. And when we start to plan with our software, the Novel Clinician, what, for example, we want to know, it's that we have really significant lower deviation if our surgical guide is tooth supported. Every single time we are in a dentist patient and we are supported by the mucosa, we can have really a lot of more mistakes, or better, the deviation is higher. And it's interesting also in the article of Razak, where we have a relationship between the deviation and the mucosal support, the thickness of the mucosa. And then, for sure, when we speak about accuracy, we have to speak about the conversion and the fusion of the DICOM file that can create and generate the deviation. For sure, the learning effect when we go for the guided surgery, complete guided surgery, is something that we have to take care about. And when we see the other information that we can find on the external evidence, so in the literature, we know, for example, that setting the ISO value for us is really important. If we set properly the ISO value, our surgical guide will be precise, otherwise we can have some deformation. And, but the most important deviation comes from the discrepancy between the guide sleeves and the bar that can have some kind of movement, and this is the angular deviation that we can have. And when we speak about lower jaw, especially if we are planning, for example, the all-on-4 and the patient cannot open really well the mouth, also this can create some kind of deviation, because you are pushing a lot, and this forces can transfer to the surgical guide and create deviation. And so for us it's really important to understand that we have a shoulder deviation, we have an angular deviation, or a maximal linear tip deviation. They are the position of the implant. For this reason, when we saw in the software the yellow area around the implant, this is the maximum deviation, and are the area where we should have this kind of mistake of the position of the implant. And if we take care about this, we never experience any kind of damage of the important anatomical structure. So we have to consider the maximum deviation as our reference for the surgery. So take care about this detail. And so at the end of all this evaluation, we can arrive to the optimal treatment planning. So for us, the optimal treatment planning in this case have evaluated the aesthetic, the function, the ideal implant placement. We are looking at long-lasting restoration, minimal trauma for the patient, and for sure a truly informed consent to the treatment, to the use the previsualization. Much more, we will be really precise in our estimate, time and money. For us, it's important, and also for our patient. So right now we are moving in the red circle, so in the irreversible phases. And so for this, we have to start to think about the provisional restoration and surgery and whatever. So for us, the provisional restoration must be a copy of what we test in the mouth through the use of the previsualization. It's a prototype of the final rehabilitation, so must evaluate also the function. And right now, I would like to speak with you about the provisional restoration, what we can have. And so when we speak about implant, we have different type of provisional restoration. Starting from the left, we have the immediate implant placement technique. So it means that we have a screw retained provisional restoration over the implant. I will avoid to use abutment and cemented provisional restoration because it's difficult to control the excess of the cement, and much more it's difficult sometimes to create nice pressure to modify and to model the tissue. And then we can have two supported provisional restoration example for the lower arch that we have there, where we can support our provisional restoration because we had already a full arch rehabilitation on implant. And so in this case we can, for example, do our GBR without any kind of pressure on the tissue. And then we can use this kind of plastic foil that are supported from the neighboring teeth, and then we can go for a full implant supported provisional restoration. Okay, and so right now we want to know how to create this provisional restoration, for example, on implant, starting from our ideal treatment plan, so from the evaluation of the clinician and our plan. So through the use of the surgical guide, we will obtain the cast to provide the provisional restoration, a precise provisional restoration. So this surgical guide are used more or less as the impression to create this nice cast with also the soft tissue replication. And then with this we are going to copy, the technician is going to copy the same aesthetic, the same position with a new works-up and positioning the teeth exactly in the right position as it was before, and was exactly what we test in the mouth that was aesthetically and functionally adapted of this patient. And then what we are going to do with the use of a verticulator, we are going to take the position of the teeth, and then we are going to create a framework, a metal framework. Why a metal framework inside the provisional restoration? For us it's really important because in this way you can avoid any kind of fracture of the provisional restoration, and so you can avoid the risk of overloading an implant that can remain alone, okay, in the mouth after the fracture of the implant. And we will see how this framework is not fitting precisely on the provisional abutment, but has some kind of gap that give us the freedom to set the provisional restoration in the mouth. And then after that we are going to use a really strong metal. In some time we can use cheap metal as well, but it's important to have something really strong in the mouth. And then after that we are going to position back the teeth in the right position through the use of the verticulator. We are going to press inside the acrylic, the pink acrylic, to create this rehabilitation. And this is what we can obtain. So it's a provisional restoration with the aesthetic with that we tested in the mouth before, and we are going to use for the immediate implant placement or for the immediate loading. And what is important? It's, as I told you, it doesn't matter that the framework fit really precisely on the abutment, or better, it's important that we have some kind of gap that can leave without tension the provisional restoration, that will find the stability through the CR position, as we spoke in the beginning. And then when we fix the provisional abutment inside the framework through the use of some acrylic, what is important is to avoid to have acrylic inside the site of the surgery, because if we have after an extraction, for example, we have contamination with this acrylic inside the socket, it's really difficult later on to detect where is the acrylic, because when it's mixed up with the blood, it becomes more or less the same looking of the bone. And so after we take off this provisional restoration fixed through the use of this little part of acrylic, we can finish out of the mouth, creating this smooth surface for our tissue. And then what about the natural teeth? For the natural teeth, after the previsualization, what we are going to do, we take an impression, so we know exactly that, for example, this previsualization was in the mouth for 1 month, 2 months, or something like this, just to test the increase of the vertical dimension, the function, and the aesthetic. And when we are ready, the technician is only to change little detail inside the shape of the impression of the previsualization, and then what they are going to do, they are going to prepare stamps, but big one, in the way to have really shells. Because if we have shells, it will be really easy for us to realign and to find the stability and the position in the occlusion. If we have really narrow stamps in some way, it's difficult to set the provisional, to sit the provisional in the right position. And then what we are going to do after we have something like this, we are going to start our preparation. About the provisionalization, we have to say also that it's important for us to develop around the implant the soft tissue shape. And so, for example, as you can see in these cases, we can develop the papilla, we can develop some kind of soft tissue shape in the way to obtain a really natural appearance in our final rehabilitation. And through the use of the provisional restoration, we can push a little bit in one side in the way to have the zenith, for example, of a central incisor, or in the way to develop an ovate pontic, and so on. I think it's really important. And then with this goal, for example, speaking about always the target of our provisional restoration, we have to understand that if we have a precise provisional restoration on natural teeth, for example, we can really have healthy soft tissue. And this is really important at the phase of the cementation, because if we have bleeding soft tissue or an inflamed situation, our cementation will not be really precise and will not be really effective. We will have some contamination of the blood. And then, for sure, after this evaluation, we, as I told you in the beginning, we consider the provisional restoration as a prototype of our final rehabilitation. And for this reason, through the use of the cross-mounting, we can really copy the shape of the provisional restoration in the final. When we speak about cross-mounting, it means that we have to copy and we have to mount the cast inside the articulator in the way that we can change the upper with the provisional restoration and the lower with the stamp, and in the opposite way. This will give us the opportunity to copy exactly these shapes. And look at here, some time to make this cross-mounting, we can also use the provisional restoration that was in the mouth for a while, like in this case, and we are not taking another bite registration. We are going to use the provisional restoration as bite registration. And so after the technician pour the master cast, I take out the provisional restoration from the mouth of the patient. I screw in this cast, in the master cast, taking care about the sitting, I mean that the provisional restoration have to sit really well on the cast, and then this is the result. So the technician have really the opportunity to copy in details what there was before. And then through the use of silicone index, look at here, we can create our works up for example, the printed press and painted technique, for example, and as you can see here, the full mouth rehabilitation copying exactly the shape of our provisional. And then, can we do something similar with the digital approach? in any case, look at here. When we speak about digital approach, what we need is to have reference point. And so in this case, for example, it's a full mouth rehabilitation on implant. We have in the upper arch 4 zygomatic implant, in the lower it's a normal all-on-4 technique. And so for reference point we need some screw that in some way will give us the opportunity to align perfectly our scanning. And look at here, after we can powder a little bit the arches, and we start to take the impression of the provisional. And then what we have to take care is to take the provisional, and as you can see here, the screw that we put in the beginning of our impression. And as you can see here, we are looking, and then we have the impression of the upper cast or the provisional restoration with this screw really well visible. We are going to do the same, exactly the same. We powder the lower arch, and through the use of the intraoral scanner we are taking the impression, looking always to this reference that are this screw that we put in the frenulum, in the furnace, and then we are taking this precise impression of the provisional restoration that was working so well in the mouth, and then we have to copy in the final restoration. And then as you can see here, it becomes really easy. It's not really difficult. It takes a couple of minutes in cases like this to take this impression, and then at the end what we want to do is to take the bite registration, and we saw before for normal situation. So in the beginning that we want to develop our relationship between the upper and the lower arch. And then when we take this impression, what we have to do is we can start finally to take the impression of the soft tissue. And just because we have this reference point that are this little screw that we put in the beginning that keep the right position, we will have the opportunity to align the first impression that we took with the provisional restoration with the second impression of the soft tissue and the multi-unit abutment, as you can see here. So you're looking right now, I'm taking care of this reference point that are my little screw, and then this is the cast that we have. And then finally we are taking the impression with our pick-up impression copying that are scan body at this time. So we have a different shape of pick-up impression copying. This is a different shape because it's important to understand what kind of shape they must have in the way to be really well recognized and in the way to have exactly the position of the implant in relation to this scan body. And as you can see also in this impression, I am taking care about the reference screw that I put in the beginning. And then we go with the lower as well, exactly as we did before. Always powdering a little bit the tissue. In the lower jaw we have to take care about the saliva because it sometimes can be a problem, so we need the important suction. And in a quite fast way right now we have the 3 different impressions. We are taking out our reference screw, and then we are going to put back the provisional restoration. Okay, it's a little trauma for the patient because we have to use a little anesthesia, but normally in a day they don't complain at all about the pain or something like this. And then what we have 3 types of impression. One is the temporary, the second is the soft tissue, and the third one are the implant, or better the implant position. And for us it's really nice to see how we can overimpose all this picture, and then the software can create an STL file in the way to create our final restoration, copying exactly what is the shape that we give in the beginning to the provisional, and then we test in the mouth. So for us this is the new approach, the new technology, and this is what we want to have as idea of our restoration. With this I would like to finish my presentation. So you saw till the provisional restoration what we have to do, and more or less what is important for us to evaluate. So I want to remember you collect all the data, evaluate the patient, looking in the face of the patient. So we have to create a facial generated treatment plan. And then for us, after our hypothesis, so the aesthetic hypothesis, we have to test in the mouth of the patient. And so speak with the patient and obtain a truly informed consent to the treatment, to the aesthetic treatment. And then through the use of the provisional restoration, all the phases that we saw before, we can obtain something really predictable that we can copy in the final restoration. And we saw in the normal way and in the digital way. I hope to see you soon with the next lecture, probably starting from this point, so from the provisional restoration to the final, in the way to understand better material and technique to obtain a really nice aesthetic. Thank you for your attention.
For more education programs, visit the Guide Institute at www.guidedental.com.